Yes, sir. So Dr. Gaurav Luthra couldn't be here because he's unwell, so he requested me, and I will be covering his talk. And I would like to thank the entire AIOS for having us here. So today's talk is going to be surface ablation, 30 years and beyond. So why surface ablation has still been around while we are talking about newer technologies like LASIK, in that femtosecond microkeratome, and also SMILE procedures. So this is how the evolution of LASIK surgery has been. We started with excimer laser, which was the PRK, and now we are talking about SMILE and Ficky Kaiwels. But PRK does come into picture when your corneas are destable or they are biomechanically weaker, they are thin or they are extremely steep or flat corneas, or where your corneal thicknesses are a little borderline, or when you're doing the refractive surgery and your RSBs are towards lower side, or the patients who are into predisposition to trauma like contact sports, or they have to go into army. That's when PRK does come into role. And there is no doubt about it that it is the best, and we have the least chances of ectasias when it comes to photorefractive keratectomies. We have various machines which can give us, where we can operate. PRKs can be done on all the machines, but trans PRK is a procedure which is a no cut, no touch technique, where the epithelium is also removed along with the laser. And you don't have to use any blades or any manual scrapers to remove the epithelium. So trans PRK is one of the very good options, and the machine and it causes least chances of pain, haze, and it has very fast recovery rates. And the aberration profiles also with trans PRKs are much better compared to that of manual PRKs or with any two-step PRKs. The trans PRKs, which is a one-step procedure right now, are offered by two machines, which is the Schwind Amaris 1050 and the Streamlight on Wave Alcon Wavelight. And the principles in both the machines are a little bit different. Schwind Amaris is the smart surf laser, where it's a reverse trans PRK, where it corrects the power first and then removes the epithelium. Whereas in Alcon Wavelight, it's a straightforward procedure where it removes the epithelium followed by the stromal ablation for the power correction, and it has an aspheric aberration profile. So our group has published work on polarization sensitivity, where you can actually image the stroma, how the collagen orientation is, how the collagen density is, and whether it's a good collagen, whether it's a weak collagen. So we compared that. We wanted to answer that whether there is a difference between PRK, SMILE, and LASIK. And what we saw was that in PRK, if you see different depths, like how the collagen is at 90 microns, 100 microns, 110 microns, and beyond, what we saw was that post-surgery, there was nil or minimal change in PRK compared to that of SMILE and LASIK. LASIK and SMILE did equally, there was collagen remodeling post-surgery, but PRK caused nil or minimal change when compared to that of a healthy eye where there was no surgery done. So this is a classic proof that yes, PRK is the most stable procedure when it comes to biomechanically weak corneas, or corneas where they are thinner, or where there are any suspicious topographies present. PRK is a way to go forward. So this is a simple, this is a video of how PRK is done. This is I think it's not playing, but the laser only removes the epithelium and stroma, and then if any refractive error is about 2 diopters, then you apply mitomycin C for 0.02% for every diopter 10 seconds, and that is after that you give a thorough wash. Just to make sure that there is no MMC related damage on your cornea or on the limbal stem cells. So that is why mitomycin C application has to be done to prevent haze. And if you are using mitomycin C, please do a thorough wash, and for every diopter you apply mitomycin C for 10 seconds. So, but why is PRK not the in spite of being the most safest, why is it not the most popular procedure in market? So one is the pain, like there is fear of pain. You are removing the epithelium, and epithelium does take 2 to 3 days for it to heal, and that's when patients might experience pain. So that is one of the fear factor. No patient want to have pain today, but that is the first concern, and the second concern is the corneal haze. So let's talk about pain. Pain is there because of the exposure of nerve endings and enhanced spontaneous activity of injured nerve fibers and release of prostaglandins and neuropeptides. There are BCLs, topical medications and oral medications present, but they all have its own challenges. So can we make the topical pharmacotherapy safer? We used ketorolac soaked BCLs where we clean the surface, we inject injected the ketorolac solution in the contact lens pack, and after 5 minutes we applied the same contact lens on the patient's eye, and we could reduce the pain with conventional with ketorolac soaked BCL from 8 to 2. So this did reduce average pain scores. But ketorolac solutions are not always available. So is there any other technique? Yes, you can use a cold BCL. You can refrigerate the BCL overnight in the refrigerator, and then just when you're doing the surgery, remove that BCL and place it on patient's eye. And the pain control with cold BCL is as good or better than ketorolac soaked BCL. And next day when patients walk into your clinic, their pain scores are like 0 or 2, and their eyes are equally quiet to what you would see in LASIK or SMILE, and they have minimal pain. So the acceptance of PRK procedure because of pain actually improves here. The second concern is the corneal haze. Now, why does corneal haze happen? This is how the normal post-refractive surgery normal wound healing happens. Whenever you do a PRK, the keratocytes do get activated, and then they get converted to myofibroblasts and fibroblasts, and then because of the normal wound healing procedure, they will get apoptotized and there will be a normal wound healing. However, if there is any inflammation present to begin with, there will be excessive activation of keratocytes, which will get converted to myofibroblasts and fibroblasts, and that is how it will lead to haze. There will not be this myofibroblast, and myofibroblast will not die on its own, but it will lead to aberrant collagen, which will depict as haze. So our group has worked on this perfect protocol where we have a very good scoring system where what we do pre-op, intra-op, and post-op. It's available freely on IGO. You can download it, and the main aim of this protocol is to control the inflammation by treating vitamin Ds. If your vitamin Ds are lower, then you need to treat patients with vitamin D because it reduces the inflammation and thus reduces the scarring. If the patients are contact lens intolerant, or if patients have, because of time I'm going to skip this slides, but if the patients are contact lens intolerant, or the patients have any pre-existing dry eye or meibomian gland dysfunction, then always pre-treat these patients with anti-inflammatory agents, steroids, lubricating drops, and a short course of cyclosporin, and then take the patients up for surgery. And of course, keep in mind about the occupation of the patients, because if the patients are indoor, then it's not a problem. But if they are outdoor and they're going to be exposed to UV radiations, then please tell them to wear UV protective sunglasses for at least 6 months to 1 year after surgery to prevent haze, and tell them why they're doing it. They will not understand why they're doing it, but if you explain to them that why they need the UV protective sunglasses, the acceptance will be better, and then that's how also you can reduce the chances of haze. So this is again published in IGO. You can freely download it. There is a scoring system. If the score is less than 5, you can take up the patient for surgery. But if there is a moderate to high score, then you pre-treat the inflammation with doxycycline, steroid eye drop, cyclosporin, and treat vitamin D. And after 1 week, you can take them up for surgery. And post-operative also, the steroid regimen will be little bit more stricter than other patients. We give prednisolone-based drops for 1 month, followed by loteprednolone, sodium hyaluronate-based lubricant, cyclosporin for at least 6 months, and treat the nutrition, because vitamin D can cause inflammation in the eye. So to summarize, PRK is the first excimer laser which was approved by FDA. It is less destabilizing to the cornea, suitable in thin, steep, and flat corneas. With advanced technologies, it is faster, safer, more effective, and customization is possible. And with implementation of targeted specific therapies, pain and haze can be minimized. So as PRK is the safest procedure, as we all know, with this protocol, you can do it safely and maximize potential for as many patients as possible. Thank you. Ma'am, we correct in our institute until 6 or 7 diopters, but outside there are reports that doctors still are correcting till 8 or 10 diopters as well. But our recommendation would be not to go beyond 6 or 7 diopters. Raja number is concerned, then you will first see why you are opting for PRK. If it was a suspicious topography, if it's a mild suspicious topography, you can opt for a SMILE extra. But if it's a higher refractive error, then phakic-IOL would be the best option. Actually, as mentioned, like people are doing it for at least 10 diopters also. So haze is not specifically because of how much tissue you burn. It is because of your ocular surface health. So you can go ahead and do it. But some reports have also suggested that haze can be because of higher ablation. So just to be on the safer side.
So we normally restrict it to 6. I don't do it. Anyway.
One question, sir.
Yeah.
Dr. POOJA,
Yes, ma'am.
do you start the prednisolone therapy or fluoromethalone therapy immediately, or you allow the epithelialization, and once the epithelialization is there, you remove the contact lens and then you start the therapy?
So we put contact lens right after surgery, and we
Yeah.
only start them on antibiotics and lubricating drops.
Okay.
And if required, topical NSAID, preservative-free and suspension-free. Once the epithelium is healed, then only we start them on steroids.
Thank
after
you.
removing the bandage contact lens.
Thank you.
Well, I have a different thing. I start both on steroids, NSAID, and antibiotics. I give 2 antibiotics. Soaked contact lens also in NSAID, and we start from day 1 because we want to reduce the inflammation. Pain. Yeah, but that doesn't last for that long. We give Equilor LS. It can, but I don't think it does. Huh? Epithelial healing, it does retard, but the point is that for the pain, the patient is very comfortable.